After arriving at an assessment of the specific symptoms the depressed elderly client exhibits, the process of setting measurable, behavioral, client-focused objectives occurs. This is the process of targeting the identified symptoms and the underlying contributing factors.
Objectives may include: 1. The client's sleep pattern will return to normal. Specify the number of hours per night. 2. The client will take responsibility for personal hygiene. Be specific, for example, brushing teeth and/or bathing. 3. The client's weight will remain stable or increase if that goal is desirable. 4. The client will attend at least one planned social activity per day. 5. The client will report no longer feeling suicidal. 6. The client will verbalize feelings of sadness and anger. 7. The client will express hope for the future. The priority, regardless of the setting, is protecting the client who is depressed from self-harm. There is a belief that people who talk about suicide won't do it. This is a myth. Always take your client seriously, and when in doubt, err on the conservative side with overprotection. As soon as you have an awareness that your client is considering suicide, call for a mental health professional's evaluation to protect your client and also to protect yourself from potential liability.
Hello, Dr. Burns. This is Grace Herwood calling from the Lutheran Home. Yes, I'm calling about one of our residents, Mr. Brandt. I'm concerned that he's more depressed. He's been talking more about suicide this morning, and I was wondering if you would be able to come in and see him today.
The client must be monitored closely until an expert deems it no longer necessary. Don't be afraid to talk to the client about suicidal thoughts. Many times, the caregiver feels frightened, thinking if the subject is brought up and it's not an issue, a seed will be planted that will lead the client to start thinking about it. This is not the case. If the person has not considered it, he is not going to, just because the caregiver raises the subject of suicide. On the other hand, if the client has thought of suicide, it is very freeing to the client when the caregiver brings it up. It lets the client know it is okay to talk about this. The message from the caregiver is, "I can handle this, and I'm not going to judge you." It is easy to ask, in an indirect way, if there is discomfort about using the word suicide.
I know this has all been very hard on you, Mr. Brandt. Have you ever felt desperate enough you wonder if it's worth going on?
I've thought about it. Wouldn't you if you were in my shoes?
Have you thought about acting on those feelings?
Yeah, but I don't know if I could do it. I don't have the guts.
What have you thought about doing?
If I had my 22 here with me, all I'd have to do is pull the trigger. Or hanging.
Do you have the means to do that, Mr. Brandt?
I could think of 10 different ways to hang myself right at this place.
A second set of interventions flow directly from the identified depressive symptoms and the objectives to return the client to an optimal level of functioning in these areas. The symptoms include change in appetite, change in sleep, the amount of energy and interest in activities of daily living and social involvement versus withdrawal. With each, the underlying principle is to begin where the client is, so as not to get into a power struggle, either by expecting more independence from the client than he or she is able to assume, or by making the client more dependent and helpless by doing for him what he can do for himself. Begin by assessing the client's ability to take care of his own personal hygiene, toileting, eating, and helping the client set small goals to increase his involvement and initiation of these activities.
Basic needs are a helpful place to start with any depressed client. The acutely ill client who feels overwhelmed and a lack of control over his or her illness can be encouraged to focus on basic self-care activities. This will enhance feelings of control and reduce feelings of helplessness. Along the same vein, Focus on hope-inspiring strategies with depressed elderly clients. Hope-inspiring strategies include 1. Thought processes clients use to change unfavorable perceptions about events to less threatening ones. We all use self-talk. What we say to ourselves can reinforce our pessimism or it can support optimism. For example, having gone through a health crisis, one client may say,
This is awful. I'll never be like I was before.
while another client may say,
Thank God it was no worse. I've been given a second chance in life.
Clients can be assisted to develop alternative ways to view problems and also help to learn techniques that stop negative thinking. Distraction through mental images of more pleasant times is one such technique. 2. Instilling the determination to fight for oneself and the desire to live are important strategies. When the caregiver does not find this present, express concern about this to the client.
Mrs. Ross, I noticed since you fell on Sunday that you're reluctant to get up and walk, even when one of us offers to walk with you.
What's the use?
Mrs. Ross, I'm worried about you. You're not fighting to get better. The staff here really cares about you, and we don't want to see you give up.
It's one disappointment after the other.
Well, you know, it's only natural to get discouraged and not want to get your hopes up, but you've been so determined in the past, and I know you want to get better and walk out of here.
The desire to protect oneself from further disappointments is strong, but this, in all likelihood, will have a negative outcome. 3. Spiritual strategies are also important, and the caregiver, in assessing coping strategies with the client, can ask whether the client can use his or her spiritual beliefs or prayer to help overcome feelings of isolation or that no one cares. 4. The client's relationship with professional caregivers can be a source of hope. Caregivers will have a very significant impact if they view the client in a positive and constructive way, convey the expectation that the client can competently handle the stressors, provide guidance, and show that they have confidence in the therapy. 5. The support of family and significant others enables the client to feel there is someone who cares. The caregiver can facilitate this by being flexible with visiting, talking with the client about his or her family, and providing the necessary support to the family so they in turn can support the client. 6. The sense of being in control is very important. Having the perception that one has the ability to affect the outcome gives a sense of power and hope. Clients should be encouraged to set small, realistic goals, and successes should be highlighted. Information about treatment and progress is a source of power. Part of the fuel for depression is negative thinking, so client progress must be pointed out. Tangible evidence of progress can be noted on a calendar for the client to review, especially when discouraged. Encouraging the client to talk about feelings is important also. When talking with a depressed elderly client, listen for common themes of stressors and loss. Utilizing the model of the stages of the grief process may be a way to plan intervention to encourage expression of feelings. Remember that following denial and bargaining are the 3 other stages of grieving: asking why me, anger, and depression. Let the client know these feelings are normal and in fact are healthy. All of us work very hard to make meaning of events in our lives. We do this by asking why. Some of the time we look within ourselves to find the answer, and perhaps then blame ourselves, feel guilty, shameful, angry at ourselves, and depressed. At other times we look outside ourselves to other persons and circumstances, and perhaps blame others and feel angry, even at whoever we view as our supreme being. Eventually, we reach a point of recognizing there are no simple explanations, and in fact, there may be no way of understanding life. We move on to forgiveness of ourselves and others, try to determine what lessons the process has taught us, and try to accept things as they are, so we can reinvest our emotional energy in new experiences. Many elderly persons with depression are given antidepressants, sometimes in the belief that the elderly will not benefit from psychotherapy, although this is not true in many cases. Sometimes the dosages given are in a subtherapeutic range. When a caregiver has elderly clients receiving drugs, they must be monitored closely for side effects. Elderly clients are particularly susceptible to adverse reactions. A thorough knowledge of the major classes of drugs used to treat depression is essential. These include the tricyclic antidepressants, the MAO inhibitors, and lithium.
Number 30, tiptoe through the tulips.
Yes, ma'am.
Okay.
A final consideration is how to develop a therapeutic milieu which will promote a healthy self-esteem, independence, and relationship building. The physical environment is important in terms of being cheerful and personalized. The climate is very much affected by the tone set by staff. There must be a constant monitoring of interactions to guard against the types of attitudes and approaches to the elderly which are present in society, either condescending or patronizing. The staff must feel supported if they are to be patient and respectful of clients. The rules must foster the therapeutic aims of the program, such as liberal visiting and phone calls. Are there creative strategies geared to the needs and deficits of the elderly, such as life review work, music, and plant and animal therapy? Given the demands on staff time, volunteers can be utilized to provide one-on-one interaction, as well as informal group activities.
In summary, depression is more prevalent among the elderly than may be generally perceived. Depression must be recognized in order for clients to receive available treatment. Caregivers have the ability to act in ways which will affect the depressed individual in a positive or adverse manner. Those who work with the aged must be taught techniques which will combat depression in elderly clients.